Just join the chapter, okay?
Copy information. Code button. Live
এটা কত হলো এটা লিংক টু শেয়ার করে অ্যাড করে দিতে করে দে আমি দেখো
code button chat up
না এটা অ্যাড করে দিই এটা অ্যাড করা হয়েছে
এই বন্ধ লাইভ live streaming is available at this
অ্যাড কর
यहाँ पे ऐड करना पड़ेगा এই যে দিয়ে তিনটা লাগিয়ে আছে কি আছে ইনভেন্টরি ইয়াত সেভ নাই কি হয় সাকসেস you lost the network connection try reconnecting
Just waiting for our Vice Chancellor to join. Hello everyone, good evening, and sorry for the delay in starting the program due to some technical problems with Google that we were having. So we were also waiting for our Vice Chancellor to join. He is also facing some technical problem, but I'm hoping that we will be able to overcome that problem. But I think we'll start with our program because there are quite a few people who are lined up to speak, and it's my privilege today to welcome you all to this international webinar on SDG sensitive risk communication and community engagement responses to COVID-19. That's a very, very lofty title that we have selected for our webinar today. The intention was manifold. Number one, most importantly, COVID-19 is a situation that all of us, we are grappling with. And it is very timely and very appropriate that we should engage in some academic dialogue around this very important issue that every segment of the society is grappling with in recent times. As a department, also, we have been engaged with this issue, issues of risk communication and social change for quite some time now. But first of all, I must take this opportunity to welcome the distinguished panelists who are here today for our inaugural session. We have the honor of having with us Mr. Siddharth Shrestha, Chief Communication for Development, UNICEF, India. Siddharth, number one, we have had a great opportunity of being in contact with Siddharth for quite a few years now. And he is a specialist in conceptualization, development, implementation, monitoring, and evaluation of communication strategies. He manages the social and behavior change communication portfolio at UNICEF, and we have had an association with Siddharth for all these years when we started our MA in Communication for Development program at Tejpur University. And he has been a person who has encouraged us in this particular journey, has been by our side, and we have had many interesting interactions with him over the last couple of years that we have known each other. We also have with us here today Dr. Supriya Desborwal. She is the Technical Officer Risk Communication with World Health Organization, Southeast Asia region. And I welcome you, Dr. Supriya, to this webinar today. And yes, that's where I would say here again comes a contribution of Siddharth to our department, that when we were thinking and conceptualizing about this webinar, and we thought that we wanted to have someone from WHO because without someone from WHO, probably we are not able to get the holistic perspective around risk communication that we are thinking of in the current context. And then Sid suggested the name of Supriya. He also helped us connect with Supriya, and Supriya graciously agreed to become part of our webinar. So thank you, Supriya, for being here, and welcome you to our department virtually. It would have been our pleasure to organize this event in a face-to-face mode, but I believe that is the challenge that we are grappling with, and we have to rise to that occasion. So Supriya is an international science and public health risk communication specialist with a very illustrious career that she has had with multiple international organizations and with WHO for a long period of time. I believe she will be able to bring us the perspective with which WHO has been working on risk communication in India during the recent times. And we would look forward to listening to you. Shukriya. We also have with us today Dr. Madhulika Jonathan. She is the Chief of Field Office, UNICEF Assam and Northeast India. Again, another person who has been a great support for us since she assumed office here in Assam. Though, again, because of the pandemic, as I was mentioning in the beginning, we have not been able to get multiple opportunities of interacting face-to-face with each other. But still, we have interacted again virtually on various occasions. And she is spearheading the activities of UNICEF in the northeastern region and also including Assam. And obviously, Tezpur University, we have had an opportunity of partnering with UNICEF Assam for a long period of time. Our partnership goes back to 2010. So it's a long-standing partnership with UNICEF Assam office that Tezpur University, various departments and sections of Tezpur University has had with UNICEF. So thank you, Madhulika, for joining us here today. Thank you. We also have with us our Vice Chancellor, Professor V.K. Jain. I'm still trying to check. I think he's still facing some problem, but I'm again hoping that he will be able to join by that time. Otherwise, maybe I'll just ask him to drop by here to our department. He's sitting in his office. He can just come to our department and maybe address from here itself. So our Vice Chancellor, Professor Vinod Kumar Jain, will also be joining us today. And we also have the most important speaker for today, the technical session. We have Professor David Moore. Great to see you, David.
Good to see you too, Joya. And congratulations on putting together this webinar. Quite a challenge.
Thank you, David. Again, I'll say David, another person with whom our interaction started in 2016 when our department was organizing a workshop under a flagship UGC program called GYAN, Global Initiatives of where international faculty are encouraged to come and stay in a particular university and interact with faculty, students, and scholars. So under that initiative, we had organized a workshop on communication for development. And then David was the resource person from Ohio University, who was here as the resource person for that workshop in way back in 2016. And we can say that that is a very crucial moment from where our journey with communication for development started in the Department of Mass Communication and Journalism, Tezpur University. And since then, we haven't looked back. And we started also our MA in Communication for Development in 2016. David has been a person who has given us suggestions on our curriculum. He has also been a very strong critique for us, and we appreciate him for being that. We always look forward to him for being that or bringing to us all the constructive criticism regarding our curriculum that he has been, and that's how we have been associated with him all this while in all the curriculum development initiatives on communication for social change. So David, Professor Emeritus, School of Media Arts and Studies, Ohio University, USA, I welcome you, David, and today we are going to have our first technical session with David. I know we will be hard-pressed for time because David in the beginning had told us that he has a doctor's appointment and we should not get him delayed for his doctor's appointment. So without much ado, I would want to start with Mr. Siddharth Shrestha and ask him to introduce the subject. To give a little background, I'll say that one thing that why we were passionate, as I kept on mentioning, that we talked about MA in Communication for Development. And then this is probably the occasion which our students need to take that opportunity. Our scholars need to take this opportunity to understand this phenomena in the right perspective, understand the significance of risk communication and health emergencies and any other sort of emergencies and the significance of communication under such emergency situations. So academically, as well as in terms of action research within a practical context while working with communities on issues of community engagement, these are concerns that we have been grappling with. And our intention here is to understand the field realities, the activities which are happening in the field, as well as the academic discourses around risk communication which are there. So that's a sort of a dialogue that we want to initiate, and that was the thinking behind planning this webinar. We have had these discussions with Mr. Suresh Parmar, who is the C4D officer with the Assam office, and through a thinking process we have arrived at this idea, and we thought that there is a lot of benefit which we can accrue out of this discussion process, and young faculty members across India would want to take this opportunity to learn from the interactions and dialogue that we plan to have as part of these 4-day long webinar that we have planned. So I'll just yes, Siddharth, I think you can start, and you want me to share your slides.
Yeah, a little later.
Okay.
Yeah, but you can, I'm happy if you can project it, at least the first one. So thank you very much, Professor Zoya. And I don't know, I cannot see the participant list, but I guess I should say good morning, good afternoon, and good evening to all participants and communication practitioners across the globe. And also to VC, VK, Mr. Professor VK Jain, of course, Joya being there, and a lot of familiar faces like Supriya here. Thanks very much for coming in. My dear friend David, I'll try to shorten my presentation so that you do not miss your dental appointment. Madhu, thanks for being there, and a whole host of other people. Of course, I would like to start by saying thank you very much to Tejpur University for inviting me to provide my remarks. I think one of the universities I have visited the most, even though it's in Assam, is Tejpur University. I think I've been there about 3 to 4 times. I was also privileged enough to be part of the distribution of the prize distribution ceremony for the first cohort of students who had passed the MA in Communication for Development Studies. So I think we go a long way. And just for everybody's information, that Tejpur University is probably the only university in India to have a full-fledged master's in C4D course. So kudos to you guys. We are, of course, very much pleased, including on behalf of Madhulika, to be pleased to be a part of this incredible journey. We not only looked at supporting this or co-creating this course, but what we had tried to do, of course, the pandemic has disarrayed our plans a little bit, but we are also looking at or already having 2 cohorts of internships of the C4D students who were working in different UNICEF. They not only actually gave their learned about it, but they were quite a few of them were instrumental in supporting our teams in documentation, in applying some of the theories they have learned practically in Assam, in Chhattisgarh, and one of them was actually also in Delhi. So I think we go a long way on this. Coming back to the conference theme, Joya had mentioned about the importance of risk communication. I will touch upon more from the practical aspect. We started working on it, and when I say we, I think I'll also bring Supriya in. That WHO and UNICEF were hand in glove since Feb 2020 to start the journey of supporting the government of India, more particularly the Ministry of Health and Family Welfare in risk communication and community engagement. So all of us, I think, have contributed in some way or the other to supporting this pandemic response. What I'm going to do now is I'm going to share with you the 7 key themes or key areas where we have learned a lot of lessons. And those lessons can not only be applied now, but also in the future. But before that, I think when you talk about RCCE or risk communication and community engagement, we all know that India is such a vast area that one size definitely does not fit all. So we had to, contextualize RCCE according to the state typologies. For example, what works in Assam, and because our office also looks at the Northeast, does not work in UP because the context is completely different. So it was quite an experience and a challenge to contextualize according to the situation. So what I'm going to share with you right now is more from the aspect of the UNICEF behavior change team in India on what we have learned so far under the 7 areas. Can we go to the slide number 2, please, Zoya? So number 1, what we learned is on capacity building. All of us know that we are still doing a lot of webinars, including this virtually. Zoya was already mentioning it would have been great, and I would have loved to be in Assam to have a physical conference like this, but I guess because of times we cannot do that. It has capacity building or training has almost been majorly online, except for some offline training which has happened initially at the block and the sub-district level. It was not the usual way of doing training and has been a challenge even now. So one lesson for us, big lesson, is that when we started in March, WHO and UNICEF supporting the Ministry of Health with other partners, we do realize that we need to do a lot of refresher trainings. Just one virtual training, we should not expect them to know and run with it, particularly when we are looking at frontline workers, when you are looking at social mobilizers. So that's one clear lesson learned for us. The other one is on the technological, it's easy technology for some, but difficult for others. So there are going to be technological glitches, and how we manage to do this is something we need to keep on exploring and employing the best technology, what is available in that particular state, district, or area. So that's something which we need to learn as we move on, cascading the approach even for the new vaccine introduction, which is going to come to us very soon. In spite of all the challenges, you see there is a whole list of bullet points saying training provided to Department of Health, NSS, NYKS, SHGs. I think we meaning everybody, under the leadership of the Ministry of Health and their respective departments in the states, within a period of, I think, 65 days, over 2.5 million frontline workers, including various youth platforms, were trained. I think that's an amazing stat. If you're doing a physical training, it was not possible at all. So good lessons learned there in terms of trying to have a huge reach within a very short period of time. That's the way to go, digital. Point number 2. Next slide, please. Data. I think what we are seeing here is data and evidence generation is absolutely key for risk communication and community engagement. even small tools, use of digital tools like UReport, as well as offline surveys, which we try to do through the communities, is always key to improve our intervention. Why? Because the situation was and is still very dynamic, right? We started with, with these 4 behaviors, COVID appropriate behaviors. We continue to do it, but there are situations where you are looking at, for example, the urban slums. The programming in urban slums is quite different from when you program in the villages, in the tribal areas. So that's why I think small behavioral insights or studies are absolutely important for that. We cannot emphasize enough on how much it has helped our RCCE programming. So the research community too has adapted and modified the methods of data collection. One thing to note here is that we did much more of online data collection than real offline because of the situation. And that's where I think we did learn a lot of lessons, that how do we do a hybrid approach of both qualitative and quantitative data collection, given the scenario of social distancing, given the scenario that we cannot do much of face-to-face interaction. Those were some of the lessons we are learning. But in spite of that, over 30 studies, the research community, the development partners came to do on various things, right from perceptions on stigma and discrimination, willingness to access services, and now we are getting into this journey of the perceptions on the new vaccine. Next, please. The third one is, I think, Supriya, my colleague, will touch upon this quite a lot, but I could not, if I don't mention about lessons learned here, I think we are missing the point. And this is a slide, of course, a graphic borrowed from WHO itself, the EPI win. But I just want to say that one of the biggest lessons learned for us, and even in other communication we need to look, is any forthcoming intervention, not just for emergency programming, but also for development, C4D work, we do need to factor in social listening, an absolutely important thing, because so much narrative is going on in the social media space, in the digital space. If you also look at digital publications, as well as in the community. So what we try to do here is look at both offline and online techniques for social listening, which has helped us a lot in trying to manage misinformation in not all the areas, but adapting as we go and not just being reactive. Next. Next slide, please. Point number 4. Again, I don't want to, everybody knows that, and I was just giving an example of the number of partners we were currently working in for rolling out the National Stigma and Discrimination, Anti-Stigma and Discrimination campaign for COVID response. These were the number of partners, but what I wanted to say is, without partnership, it would absolutely not have been able to reach the length and breadth of a huge country like India. So right now I'm just showing you these 13 partners, but there were about 26 partners helping us, including digital Goliaths like Facebook and Twitter and the world. What I wanted to really touch upon is, in spite of all the partners, one of the lessons learned is our engagement with WHO and UNICEF and other partners. We really, really engaged and brought the faith-based leaders, into the conversation. They, in spite of having to do digital communication, has really helped in curbing some of the stigma and discrimination, promoting the COVID appropriate behaviors, because they do have a very strong following, which is not possible just by development partners or not just by the government counterparts. So the role of faith-based leaders has been key in all of this, including celebrities like Amitabh Bachchan. As you see, that was the first ringtone which came out in March with his voice on COVID appropriate behaviors. Next. Again, this is something I hope you can discuss as the webinar, this international webinar goes along. This is food for thought: digital engagement versus community engagement. Because as we know, it was not business as usual for SBCC, and in this unprecedented situation, we have had to use more of digital communication than real-time community engagement. So we have had to rely on this. The SBCC experts has had to rely on this specific skill sets for a long time. It's easy when it's done face to face, but when you do it digital, we have a lot of, there are issues to this. But in spite of all these issues, I think the SPCC community, at least as far as my knowledge goes in India, has managed to quickly modify, adapt, and innovate to manage community mobilization and counseling. So I think kudos to all of us. In this process, I think exploring and learning how to use digital tools has been quite a revelation for not only generating awareness, but moving towards changing attitudes. The question is how we move on with the right mix of using digital and social community engagement, because digital engagement is here to stay, and which we as behavior change practitioners really need to include this in all our communications moving forward. Next up. We all believe in this, and I keep on being a very strong hand washing propagate that there has never been a better opportunity to sustain hand washing. New results are showing that hand washing rates are going up because one of the key behaviors under COVID appropriate behaviors is hand washing with soap. So I think we are all champions to help us promote and make sure that hand washing is there to be sustained and not just for the emergency response. It's going to be very important also in the COVID vaccine rollout. Next. And finally, in the midst of responding to emergency situations, we tend to forget these important aspects of gender and equity lens. So just giving you some examples of, to ensure that the gender, lens is not left out while designing communication materials. Three agencies, actually also WHO, were provided feedback on this. On when we develop materials, what are those gender aspects we need to look at? So we had developed this checklist, which was used for a variety of communication materials. And similarly, with looking at the vulnerable population, the COVID response, for instance, we did roll out a lot of community radio, though it has a much limited reach, and it is an expensive proposition compared to the FMs, which have a huge reach. Community radio stations are in areas which are very remote. So we do need to also use communication channels from a equity lens. Next. I think, that's about it. Thank you very much. I tried to limit it, but I think it just went a little bit overboard. Finally, I just want to say that there has been a lot of preparations right now for, from a communications aspect, for the rollout of the COVID-19 vaccine. All these lessons will be instrumental as we go forward, as we move forward, and happy to answer any queries you might have. Over to you, Jaya.
Thank you, Siddharth. You have actually flagged probably all the right concerns. Something which I found very connected and very thought-provoking is when you raise the question regarding digital engagements versus community engagement. It brings to me one question. Has Digital India really arrived? And are we able to sustain this transfer from community engagement? Do we actually have the scope to shift from community engagement to digital engagement? What sort of a balance needs to happen between these two things? Given the type of discussions that we have been hearing from multiple stakeholders, talking about the problems with regard to the digital engagement, the problem which has happened in education sector, in various other sectors because of the problems of the digital engagement. So that's probably one aspect that we will have to deal with in the long run. So that's an open question. I believe we will be able to answer it in the various discussions that we have in the process.
I have a question, Siddharth.
We will take questions a little later. I think we will first of all go ahead with the initial comments, and we have a scope for question answers towards the end because we had a little problem in the beginning to start on time. So we'll just try and go ahead now. I would now invite Dr. Shupriya Desporua, Technical Officer Risk Communication, WHO Southeast Asia region, to share her thoughts on our theme and her engagement, the WHO's engagement with regard to risk communication. Over to Supriya.
Thank you very much, Joya. Thank you for inviting me to this webinar, and thanks to Sid as well for connecting me. It's such a pleasure to speak to you because, as you know, I'm from Assam.
Yes.
I left Assam. I grew up in Shillong and Guwahati. I left Assam when I was about 18. But as they say, you can take the person out of Assam, but you can never take Assam out of the person. So my heart is still very much there. That's still home.
We would love to have you here on our campus. I think this is the beginning of a new partnership. Yes, Supriya, over.
Well, it's even online. It's a great pleasure to meet all of you. And of course, you know, in future, if you can meet in person, that would be wonderful. But and I'm also delighted at that the level of interest in this subject in risk communication, because since we're talking about SDGs, being from WHO, of course, I'm interested in SDG 3, but I work specifically for the Health Emergencies Program in WHO. And in emergencies, the key thing we follow, the key rules, if you like, is something called international health regulations. It guides us completely. It's a legally binding document that mandates what countries need to do, which prepares countries for emergencies. And it was revised and updated after SARS happened in the early 2000s. And the key to the whole point of IHR is to prepare countries for specifically, a pandemic like this, which WHO has been warning about for a very long time. And it has identified several core capacities to do that. For example, you should have strengthened lab capacities, you should have strengthened epidemiological capacities, you should have clinical management capacities. But among those key core capacities, right from the beginning, is risk communication and community engagement. And why is that in emergencies? It's because at the end of the day, you can have your drugs, you can have your treatment, you can have your vaccines, you can have any of it. But unless people know what to do, and unless people not only know, but actually do it, you're nowhere, you can't progress. And for that, people need to feel confident enough to take the drug or take the vaccine or wash your hands or wear a mask or whatever it is. And therefore, I feel anyway that risk communication and community engagement is probably one of the most potent public health tools there are. And I'm glad to say that that's really something that countries in the Southeast Asia region, which I work, including India, have recognized now and is really focusing on a lot. But it's also, and there are 5 areas, according to IHR, where risk communication focuses on. One is risk communication systems. So that means that and so I'm delighted that Sid mentioned capacity building. It means that A country should have risk communication as part of the system. If there's an outbreak, you should have systems in place to respond to it through communication as well as through other means. The second is partner coordination. What happens in an emergency is that you have a number of players, all of them working, it's like the elephant and the proverbial elephant and the three blind men. So each one looks at their own little area, but you often don't get the bigger picture unless you have coordination and partnership. So that's the second important thing of risk communication under IHR. The third, of course, is public communication, which when I joined, and that tells you how long I've been in this business, was mainly traditional media communication. But now, of course, it's digital media, as Sid has very nicely pointed out as well. The fourth is community engagement. And I feel that's critical, and when Sid mentions digital engagement or community engagement or both, I feel that you cannot do without community engagement, and I'll tell you why. And the fifth is listening. Listening is the key to communication, and you really can't do. You can't get anywhere without it. And listening increasingly for us has meant digital listening, social listening, and also tracking misinformation and disinformation, which has increasingly, become a bigger and bigger problem in communicating. It's an area that has changed rapidly. When I first joined WHO way back in early 2005, after the tsunami of 2005, which affected multiple countries. At that time, just to give you an example, there wasn't, I think Facebook had just arrived, but there was no Twitter, and there was definitely no WhatsApp. So life was, in a sense, simpler. Now things have changed quite a lot. Now, the major thing that we face is what we call infodemic. Infodemic usually refers to misinformation and fake news, but it's much more than that. It just means that there's just so much information out there that you don't know what's right, what's wrong, what you should believe, what you shouldn't believe, and you get completely overwhelmed. And that's something that we've been, especially with COVID-19, we've been trying to focus on. We've been trying to figure out how people look at information, in this plethora of information that's there. Who do they believe, and why do they believe that? How is information spreading? Also, can people recognize fake news versus real news? Who do they think is credible? These are some of the questions we've been asking and looking at in WHO globally. Also in Southeast Asia, we've started a rumor repository looking at social media and tracking social media and looking at the fake news. But of course, most of the rumors, as we know, spread through WhatsApp, so that's not always very effective. Very often we get to know well after the rumors spread. Then we also look at, as I said, we listen also for public insights through digital monitoring. But again, the way social media works is that the people you hear are the people who are the loudest. So you look at influencers, you look at the people who are, have the most engagement, and you think, they are the ones who are shaping public thought. But if you look at the number of engagements, they may be high, but not as high as the number of people on social media, many of whom are quiet. So you don't many of them who just log on to see what's in there, but may not be overtly expressing their opinion. So we also need to be careful about how we interpret, how we look at social media and look at the infodemic. These are some of the things we've been looking at and has been a challenge with COVID-19 particularly. But the reason why I will to refer back to what Sid said is I feel community engagement is most important is because in communication in emergencies, it's our biggest challenge is that people are at when there's a new emergency, there's a lot of fear and there's a lot of confusion and there's a lot of terror. And research has shown that when that happens, people go biologically into what's called a fight, flight, or freeze mode. People no longer function rationally, and there've even been MRI studies that show that people here, this is the thinking part of the human beings, right? And at the back of your head, not quite the back of the head, but there's another part that's the emotional, part of human beings. And MRI studies have shown that, initially when people get some shocking news, it's the emotional part that lights up. And only a few minutes later, it's the rational part that lights up. So people react emotionally and not rationally in an emergency. And they're often not in a situation where they can listen to rational argument or absorb new ideas or thoughts, which is why preparedness is so important and that's why community engagement and face-to-face engagement is so important, because in an increasingly digitalized world, people still like to listen to someone who tells them, someone they trust, someone they know, to make sense of what is happening and all the, amount of information that's up there. It still boils down to trust. And that is why I think we need to focus on at least as much on community engagement, at least as much on reaching out to people, speaking to them, understanding what they think and getting their point of view. And that's, I think, how we need to go forward. COVID-19, of course, has been unique in a sense that it's brought all the issues up front in every way, in a manner that has never been seen before. But moving ahead, people are talking about vaccines, and we will see more of it, more of misinformation, more of over-information and the infodemic. But people are also hitting what's called pandemic fatigue. People are fed up of following the same messages. Although awareness is high, people just now feel, okay, we can't take it anymore. We just want to go back to normal. So how do you deal with that? That cannot be done through digital media. That has to be through a combination of a traditional and digital communication and face-to-face communication and community engagement. So also the vaccine rollout is unique. This is the first time that probably on this scale you'll have adult vaccination rollout. It's not children who are going to be vaccinated this time. The priority groups are healthcare workers and the elderly, which is a totally different population group. And the elderly, the adults already have a very strong idea of what they want from their health. They also have especially in our culture, most adults would say, no, I don't want the vaccine. I want my child to get it. So there are unique issues that will be coming up. And of course, Sid, at the country level, I know has been working very hard on this with his team. UNICEF's been leading on vaccine communication. But more and more, as we move ahead, we'll have unique challenges. But the one thing that remains is you have to reach out and get people to trust you. You have to reach out to people who are trusted. At the end of the day, the one thing that hasn't changed in risk communication is the need for trust. And the need to listen to people and listen to their wisdom, and the need for trust. And I think those are the two key messages that I would like to leave you with. I will not take more time because I know there's someone who has a doctor's appointment or something and needs to go soon. But I hope that's been useful. Thank you very much.
Thank you, Supriya. Thank you. I think you have also again rightly pointed out the balance between the digital engagement and the community engagement. And we are again going back to a very basic context where you are talking about trust. The balance between the rational mind and the emotional mind. Even during the vaccination, we are now seeing reports in newspapers where we are trying to create awareness about vaccination, because there is already a fear that people might be rejecting the vaccines. There is a lot of, again, propaganda which is happening, a lot of misinformation which is getting circulated in social media with regard to the vaccines and who should take it, who should not take it. So already there is a lot of communication which is also happening in traditional media or legacy media with regard to creating or cleaning up all those misinformation which is there. And obviously, as you say, the focus this time is the adult, and they are more onto social media and not the children here, that someone else is going to decide for them. Here people are going to now decide for themselves, and this balance between the rational mind and the emotional mind, the factor of trust, a very, very interesting situation. Essentially, I'm looking at it from a purely academic point of view and saying this. So now we would want to have, and we want to call in Dr. Madhulika Jonathan, Chief of Field Office, UNICEF, Assam and Northeast India. Madhulika, your take as to how you are engaging and with issues concerning children within the northeastern region, and also like when there is so much of focus on COVID-19, there is so much else which is also getting lost in the process. So Madhulika, over to you.
Thank you, Zaya. Do you hear me well?
Yes, we can.
Okay, thank you. Acknowledging Professor Vinod Kumar Jain, Vice Chancellor, Tezpur University, Professor David, from Ohio University, Dr. Supriya just spoke, my colleague Sid from UNICEF India, Professor Sunil Kantabera, who is from the Department of Mass Communication, my colleague Suresh, the Communication for Development Specialist in Assam. Good morning, good evening, and good afternoon, wherever you are, and warm welcome to participants virtually to Assam. I would like to congratulate the Department of Mass Communication and Journalism, Tezpur University, my UNICEF colleagues for collaborating to organize this, and I know that this has been a very interesting journey to put it where it is, the international webinar on STD-sensitive risk communication and community engagement. UNICEF, just to share, UNICEF in collaboration with the Department of Mass Communication and Journalism, Tezpur University, had launched the master's course in 2016. And that was the beginning of a very important and interesting journey for us because it then created within the northeast of India a pool of trained communication for development professionals who would then be trained to serve in the northeast states and strengthen implementation of the community demand generation component, especially of development programs. And this was very specifically designed with the 6 months internship program, providing meaningful learning experience to the graduates, as well as provide a different perspective in the programs where they participated. UNICEF further works with the Department of Cultural Studies in Tezpur University for the implementation of folklore interventions and adolescent empowerment, largely for the tea garden areas in Assam. Beyond communication, our work has also been with social policy, Department of Sociology, as well as the Department of Social Work for nutrition. Coming back to the theme of this webinar, the COVID-19 pandemic, as you know, Sid has flagged, Dr. Supriya has said, it has been a very, I would say, unprecedented global, both health, humanitarian, human rights crisis. And public health measures which were introduced, such as physical distancing, and also largely to reduce the transmission of COVID-19. In the context of children and women, further increased protection risks and vulnerabilities for already at-risk groups, especially crisis-affected families. And women and children are, I would say, more vulnerable to the impact of COVID-19 response, largely because of the additional care burden on their shoulders. They were at the risk of gender-based violence, as they were often in close environments with their perpetrators, largely due to lockdowns and movement restrictions. I think another spin-off, and not such a nice spin-off, is the loss of household income for very poor and vulnerable families, including migrant workers. And I think that was the most painful. The stories, the pictures that are painted in our mind are very, very painful. And this really affected, I would say, the financial capacities of parents and caregivers to access nutritious and affordable foods and basic social services, which are essential to fulfilling a child's growth and development. And while the government, and I want to congratulate the government for that also, because they did come in with specific social protection schemes. I think in many states and in many governments, I think beyond India, those who were in low-income settings, governments in low-income settings, they were restricted with limited financial capacities and also limited trained personnel, and often would include, external populations coming in, like migrants and people coming in from displaced households who were really not part of their original group who they had either planned for or line-listed. Another issue that we worked with in Assam, and I think at the global level as well, the issue is common, that while health professionals and frontline workers contributed to the medical response to COVID, risk communication and community engagement continued to remain, as Dr. Supriya shared just now, it continued to remain and will remain critical to provide correct information, promote safe behaviors, prevent stigma and discrimination, and build partnerships and community ownership to respond to the pandemic. Here in Assam, UNICEF provided support for Assam as well as the Northeast states, and major areas of focus largely were capacity development, also developing specific packages for risk communication. Even in the states, like I remember the state of Sikkim had reached out to us, Arunachal had reached out to us, beyond Assam. So there were many states who actually reached out to us for packages of how they could transact some of these messages, or rather all of these messages, along with the medical and technical material that was available, so that they could strengthen and make their communities more resilient to this pandemic. Another thing that we felt and we hoped that that has also garnered results and brought more of the same is the convening role that was that we were able to play. And Sid shared how many partners, many CSOs came together to provide support. Some of the other things that we had to address, and I think it was also addressed well by the government of India, was the stigma and discrimination that many health workers faced at this time, and including people who were affected by COVID. And the efforts were made then, as Sid shared, to work with leaders. Locally elected leaders, NGOs, community volunteers, faith-based leaders, academic institutions, counselors on prevention of stigma and discrimination. And as the migrant workers returned to Assam and Northeast, new issues emerged, and I would say a blended and differential risk communication, community engagement strategy had to be, I would say, envisioned, designed. A task force developed. A task force on migration was developed with broad strategies and framework to work on the different issues of the migrant population. This was shared with the government as well as with the national government. Continuity of health, nutrition, education, protection, and water sanitation, essential services remain at the core of our work, and was a very critical piece that we had to look at post-lockdown. And in collaboration with state governments, UNICEF continued to work with partners so that we could continue to engage with communities and continue to encourage demand generation of COVID-sensitive services. Few learnings that my colleague Suresh, our specialist, also wanted what he has shared with me, and just trying to put it together in a collaborative way. What has happened in the region. When the RCCE messages were combined with correct information on entitlements, essential services, education, protection, psychosocial support, the returns were stronger, more sustainable, more people listened, more people connected. When new behaviors of mask wearing and physical distancing, they were introduced, and I will also come to the point of fatigue of some of these behaviors. I think one thing we learned was that a shared seriousness, a shared importance that each stakeholder must give to these behaviors is very critical. Partnership with key stakeholders and organizations who are working in this region. And we also, at the same time, did a huge mapping of partners who are working in this region so that we could engage with them, we could share with them. Blended approaches of both offline and online engagement for COVID-specific and sensitive messages is very critical. Finally, community as well as service providers are definitely showing a fatigue in maintaining behaviors, and this requires strategic adaptation and a creative, non-conventional approach. Storytelling, folklore has been a big success, alignment with other priorities of the community to demonstrate, they demonstrate this true potential. I would like to end largely by sharing the collective efforts by the government, academic institutions, civil society, but with our UN partners, WHO, UNDP, working in the region. And it's very critical to be together, to understand, to work together, not only for the communities that we work with, but even for the security and safety of the UN personnel in this region. I think the whole point of collaboration, the whole point of coming together is what will finally give us sustainability as well as results. So I wish you best for the upcoming seminar, the webinars that are planned for the next 2 days. So wishing you all the best. Thank you so much.
Thank you, Madhulika. Yes, rightly you are highlighting the reason for partnerships. I believe we started talking about in terms of building the partnerships which need to happen. When we are talking about a pandemic, there are so many stakeholders to that process. The service providers as well as people who are at the receiving end and the existing structures which are there within the community. So we cannot work while negating the existing structure and by superimposing something which is entirely new on a community. The communication infrastructure also and the communication networks which are inherent within communities need to be rejuvenated and need to be worked upon, and we have to develop those partnerships between the new sorts of engagement, even if we are talking about the digital engagements and the existing networks of communication which are there at a community level. So these balances and striking those partnerships with the multiple stakeholders. And you are also talking about the added aspect to it when we are talking about the migrant populations at that particular point of time. So that's another sort of a humanitarian crisis as well, to which we need to respond to, apart from while dealing with the pandemic side by side. So yes, rightly so, multiple dimensions to an issue, and let us not just look at it as a pandemic and where it's a health crisis and we are dealing with it. Thank you, Madhulika, for bringing to us the big picture, I would say, in terms of the context of COVID-19 with which we are grappling. I would now want to welcome and also invite our Vice Chancellor, Professor Vinod Kumar Jain. Sir, we are sorry that in the beginning we were having some technical problems. Google was showing some problems and we also could not start on time for that. Also we were facing problems so that you also could not log in on time. But sir, we have had some interesting discussions where, if I may just brief you with that, we have had Chief Communication for Development UNICEF India, Mr. Siddharth Sresht, who spoke in the beginning and highlighted the different aspects of engagement that we need to have while dealing with COVID-19 and the importance and significance of risk communication. We also had Dr. Supriya Bezburua. I believe you have been able to hear her a little. She was the Technical Officer Risk Communication, WHO Southeast Asia region. Even Dr. Supriya spoke about the capacity building and the balance between the digital engagement and community engagement, which is required during the times of COVID-19 with regard to risk communication. And then we had Dr. Madhulika. I believe you could hear her. Sir, your words as an inaugural note for the webinar, the 4-day webinar that we are organizing on risk communication and community engagement during the times of COVID-19. Sir, over to you.
Thank you, Professor Chakravarti. Mr. Siddharth Shrestha, Dr. Supriya Bezburua, Dr. Madhulika Jonathan, Professor Sunil Kant Behra, and all of you who are virtually connected with this international webinar. May I extend a very warm welcome on behalf of Tejpur University and take this opportunity to sincerely appreciate the efforts of Department of Mass Comm and Journalism, and in particular the very energetic young professor Joya Chakravarti for taking this initiative in partnership with UNICEF. And I must put on record our sincere gratitude to UNICEF for always, be forthcoming in forging partnership with Tejpur University for various academic linkages. Madhulika did talk about the various engagements, whether it is with the cultural department or with the mass comm department, or even a postgraduate diploma which we are offering in collaboration with you through Center for Inclusive Development. So we really are very thankful and hope that this partnership would further get strengthened, because these days, this is the age of forging linkages and partnerships and collaborations, and we can leverage the strengths of each other for more meaningful outcomes. Having said that, as has been mentioned, this COVID-19 pandemic, various dimensions were mentioned by previous speakers. But the world, as you know, has, world around us has changed dramatically. And different countries are dealing with it in their own ways, some not so successfully, but to the credit of the Indian government, they have not done too badly. And this is true that in a country like ours, where you have such diversity across religious faiths, the social groups, and within the social groups too, you have, very backward classes and so on. You did mention, some of you did mention about the people who are more vulnerable in this pandemic, especially the children, the elderly, and so on. But it is, for me, the people, whether they're children or women or the elderly, but in the social groups, which over the years, which have not really got the benefit of the economic progress of the country, who have been left behind in the so-called developmental race. They are the most vulnerable. And in fact, if you look at the SDG, goal number 3, health and well-being, by year 2030, when all these goals are sought to be accomplished, the problem is that much more complicated, because this pandemic has, as you all are aware, has twin dimensions, especially of the health and the economic well-being both, and they go hand in hand. And the problem becomes even more compounded for these social groups, which are already lagging in terms of the financial resources and other resources. So it is in this context that the Indian government has been very proactive, led by our very dynamic Prime Minister Modi, and with the concerted effort of various agencies like WHO, ICMR, and other NGOs, including UNICEF. And so the country has been able to manage the impact of this COVID somewhat. But in this context, as has been mentioned, that the communication strategies are extremely important. And it is in this context that the UNICEF's work on risk communication and community engagement is pretty laudable. And I'm sure the students and the faculty and all those who are in the field of communication would hugely benefit from the deliberations which are likely to take place over the next 3 days. And we would also have the benefit of some eminent speakers from abroad. And that way we would be able to get some exposure as to, what is it in terms of the strategy which some of these countries have employed to deal with the situation. So it is going to be quite a learning experience for all of us. So thank you, Joya, for inviting me, although I'm not an expert in any way in the field of communication, but certainly this is a very useful exercise. And especially, God forbid, if such a situation recurs in future, we would be that much wiser if we share our good practices in dealing with this situation. So thank you, and wish you a very productive and meaningful 3 days of deliberations. Thank you.
Thank you, sir. Thank you for finding time to be here. And we really look forward to hearing from the distinguished panel of experts that we have who have given their consent to be part of our program. And so today, immediately after the inauguration program, we look forward to hearing from Professor David Mould. He is already here with us. He has already joined from Ohio University. So that will be the first technical session today. But before we move on to Professor David Mould, who is to speak immediately after this, I would want to invite Professor Sunil Kant Behra to Professor, Department of Mass Communication and Journalism, to give the concluding remarks for the inaugural session of today. And after that, immediately after that, we will proceed to the first technical session with Professor David H. Mould. Over to you, Behra sir.
Thank you, Professor Daya Chakravarti. And I was listening to all the speakers, Siddharth Shrestha and Madhulika, and also Supriya Bezvarwaji, and our Honorable Vice Chancellor also talked a lot about the impact of COVID and the need for risk communication and the community engagement. And I know Professor Mould is waiting to start his speech at 7:30 as he has an engagement with the doctor. So very briefly, I will tell you whatever that Siddharth had said. Very rightly, he talked about the importance of training, the capacity building and training of the frontline health workers in such a pandemic. And the good thing is that they have been able to train about 2.5 million frontline workers within the time frame of 65 days. With online and offline workshops, they have been able to train the frontline worker, 2.5 million all over the country. And also he stressed upon the collaboration with the other stakeholders. They worked with the Government of India, Ministry of Health and Family Welfare, the World Health Organization, UNDP, and other agencies in our country also. They have collaborated with them, and a blended mode of campaign they had in dealing with the health pandemic or the COVID-19 pandemic. He also stressed upon the fact that talked about the digital engagement versus community engagement. The Digital India, I know the Government of India has planned a lot for the Digital India campaign and had a Digital India program, and still the digital engagement is to go further, and certainly the digital communication plays an important role in ensuring community engagement, not only during such a pandemic, but also in other times. And also the most important thing that the campaign regarding the anti-stigma and discrimination. Now, we all know that we have faced, the frontline health workers have faced stigma and discrimination, as well as even the COVID patient faced stigma and discrimination in the initial phase. But fortunately, with these interventions by the communicators from WHO and UNICEF and also the Government of India and other agencies, people have really understood towards the mid of the crisis that stigmatization and discrimination should be done away with. And people have accepted the COVID-19 as something which is happening to us, and there should not be any social stigma and discrimination. That's a very, very important thing. And the gender equity also has been dealt with during this campaigning regarding risk communication and community engagement campaigns. That's what Siddharth has very rightly pointed out. And Supriya Bezvarwa from the World Health Organization, she very rightly talked about the international health regulations, which were formulated in 2005. And that was the first regulations framed by the World Health Organization, to which all the WHO members, World Health Organization member nations, agreed to use risk communication to deal with such a health pandemic.
Sound.
And they have also agreed to integrate risk communication in the general framework of health campaign or health system. And he also talked about the capacity building. Collaboration is the buzzword in the management of COVID-19. And she talked also about the listening, the importance of listening. Both Siddharth and Supriya both talked about the importance of social listening. Social listening may be digital listening, may be social physical listening, but it's all about feedback. We need to listen to people while formulating campaigns and plans and programs to deal with this pandemic, any pandemic, whether health or natural disaster or any such pandemic. We need to listen to people because they are the people who are affected. They are the people we need to protect them. So that is the reason why listening is very, very important. And Dr. Madhulika Jonathan very rightly talked about what are the initiatives taken during the COVID-19 pandemic in Assam and also the northeastern states. And she talked about the work undertaken for the women and the vulnerable sections of the societies. And also she very rightly pointed out about the gender-based violence that happened during this lockdown. That became a major concern for us. And she also talked about the effect of pandemic on the financial capacities. We all know we have a limited financial capacities and limited trained personnel. Again, the problem of migrant labor cropped up. So how to deal with such situation during a pandemic? They had developed a humanitarian campaign to deal with such issues. And she also talked about the stigma and discrimination faced by the health frontline workers as well as the COVID-19 patients. What she urged upon is to have a blended risk communication strategy, and we need to have a task force to deal with such issues. And she talked about community as strategic adoption and the collective efforts. She talked about the collective efforts of the government, UNICEF, World Health Organization, UNDP, and also the educational institutions, the teachers who also helped and worked as risk communicators during this pandemic. Our Vice Chancellor, Professor Jain, very rightly talked about the proactive measures actually taken by the Government of India and in dealing with the sudden and the huge health pandemic in a country of about 138 crore people, population. It's not easy. And the pandemic is seen very differently in different parts of the country. You need to contextualize the campaigns, you need to contextualize the programs, and the Government of India very rightly in a more decentralized way. The Ministry of Health and Family Welfare in collaboration with UNICEF and WHO, they were in touch with the ministries, the health ministries of various state governments, and they worked in unison and dealt with this pandemic, for which today the COVID infected population has come down to about almost 3 lakh. 97% of 97.3% of the infected population have already been recovered. So we are on the path of recovery. And Professor Jain also talked about the need for the right kind of communication strategies to deal with such situations or such pandemics in future. And he stressed upon the fact that the Government of India, in collaboration with global agencies, will be able to develop strategies to deal with such situations in future. So that was what has been the summary of this inaugural session. But to sum up, let me say, it is not, I will give you a little bit of information. What Supriya was talking about, the international health regulations, the World Health Organization, again, they have worked after particularly the pandemics like SARS in 2003, then the H1N1 influenza in 2009. Then we had this Zika virus in 2015-16, Ebola virus pandemic in 2014-15, and then the yellow fever virus outbreak in 2016. Then the WHO actually started in formulating. They formed a group and started to formulate guidelines, general guidelines for dealing with pandemics. And in 2017, they came up with a sort of guidelines, evidence-based guidelines. They talked to the people, they worked in the sector, and they talked to the experts, they talked to the affected people, and the guidelines have been formulated under three different heads. One is building trust and engaging with affected populations. B, integrating emergency risk communication into health and emergency response system. It's not only risk communication should function during the pandemic, but it should be integrated into the health and emergency response systems. And then the ERC practice, emergency risk communication practice, when it comes to the building of trust, that is the one is trust, and because what is more important is we are communicating uncertainty. We do not know what is right, and we do not know many things about, say, for example, COVID-19. So whatever little information that we are getting from WHO, whatever little information that we are getting from other agencies, we were communicating to people. And there were certain things which neither people knew about it, nor we have been able to communicate those things. So we were communicating uncertainties actually. So there we will have to develop a right kind of strategy to balance and deal with such situations. And then should be community engagement, which is very, very important. Once you build up the trust, then we can ensure community engagement. Then integrating ERC into health and emergency response system, where governance and leadership is very, very important. They talked about certain guidelines. Second is information systems and coordination. Third is capacity building. What is more important again here? Training the personnel, and it should not be again during the pandemic times. Capacity building should be an ongoing process to train people to deal with such pandemics. May not be health, but it may be other kind of pandemics, natural disasters also. And then the financial allocation and strategic. Then the practice. When it comes to ERC practice, what Professor Jain was talking about, strategic communication planning. That is very important, and the World Health Organization has all talked vividly about this requirement. And then monitoring and evaluation is very, very important. Then also social media engagement. Even if social media, we say that there are a lot of misinformation campaigns, there are a lot of fake news, but social media is a reality. It has come to stay. So how positively and proactively we use the social media, and do we draw the feedback from social media, that we need to develop a strategy. And then again the messaging system, the contextualization, what Professor Siddharth contextualizing the message, you need to identify the right kind of media that will reach these people. So all these guidelines have been developed by the WHO, and I am sure these guidelines will be taken care of by the respective government of the WHO members, and also with the collaboration with all these agencies, we will certainly be able to deal with the COVID-19, present COVID-19, and it will tide over the crisis. Thank you very much, Professor Jaya Chakravarti, for giving me this time. And it was really a learning experience to hear Siddharth and Madhulika, and also Supriya and Professor Jain. And I am looking forward to hear Professor Ball. Thank you.
Thank you, Professor Behra, for the concluding remarks. And now we move on to our first technical session with Professor David Mould. I believe all of us, we are familiar with the name of Professor David Mould, but still, I would take this opportunity to introduce him to everybody, but I'm also at a loss as to how to introduce David. Whether he is an academician, he is a C4D practitioner, he is a journalist, or he is a travel writer, or I don't know who he is. So it's a multifaceted personality that we see in David. And to say the list, the most humble, the most approachable professor that probably we have come across, in spite of the in-depth knowledge that he has on communication for development, communication for social change, and the way he makes the subject so interesting, so dear and near for anybody who has the opportunity to listen to him. So, but still, for a very formal introduction of David, I would say Professor David H. Moore is Professor Emeritus of Media Arts and Studies at Ohio University, where he has a 30-year career as a teacher and administrator. He has traveled widely in Asia and Southern Africa as a trainer, consultant, and researcher. Before moving to United States, he worked as a newspaper and television journalist. So he has had a career as a journalist. In his vast array of career as a journalist, historian, and college professor, he has visited more than 40 countries. For the last 25 years, he has worked in Central and South Asia and Southern Africa as a teacher, trainer, researcher, and media consultant. And most recently, he has been working with UNICEF a lot. He has been working with UNICEF India, UNICEF Bangladesh, and that is where we get the opportunity of seeing him and meeting him. He has produced numerous public radio and television documentary series and is the author of books on news, film in World War I, transportation history, and oral history. His books on travel, history and culture, postcards from Stanley, journeys in Central Asia, monsoon postcards, more recently Indian Ocean journeys, indicates about his passion for writing. So he is a multifaceted personality who brings in all his skills in journalism, in C4D, as a media faculty, everything rolled into one. So David, and he's going to talk about risk communication in emergencies, principles, and practices. So again, thank you, David. He responds to our request whenever we make a request to him. So over to you, David.
Okay, thank you very much, Dr. Chakraborty. Can you bring up my PowerPoint?
Yes.
Okay, good. Well, welcome everybody. Very happy to be joining you this morning. I live in Charleston, West Virginia. And I guess I want to start by just referring to something that the Vice Chancellor, Dr. Jean, said a few minutes ago, where he hoped that this webinar would introduce some perspectives on successful communication strategies from other countries. Well, I hope you will exclude the United States from that category because I think the communication response in the United States has been very uneven and has had all sorts of issues. To pick up on a point that both Sid and I think Supriya made, the response in the United States in terms of communication has been decentralized but not contextualized, if I could make that distinction there. In other words, it's been shoved down to states as political units and they've been told to get on with it. I'll certainly take some questions at the end, but I'm very loath to try to offer any best practices from the United States because I think that I think other countries have been much more successful and much more strategic in their approach. Okay, do we have the PowerPoint there? And also, I apologize for my medical appointment this morning. I hate for this to sort of drive the webinar. I do have it, but it's nothing serious. It's not like I'm going in for brain surgery or anything like that. You know, it's a regular medical appointment. Okay, well, it's a little daunting, I think, to. Are we all seeing it okay, Joya? Okay.
Is it visible?
It's visible to me, except it says page on the bottom and stuff like that. If it's visible to everybody else, that's perfectly okay. How does it look on your screen? Does it look okay on your screen?
It seems to be okay for me.
Okay.
It's
Well,
okay. It's okay.
Yeah.
It's okay.
Okay. Good. Thank you, Sunil. Okay. So it's a little daunting to follow in the footsteps of Sid and Supriya and Madhulika, because they've covered some really key points so far. And so I'm going to kind of reinforce some of the points that they made, but maybe come at them from a different perspective. And as we know in communication, the more reinforcement you get through various channels, maybe the more effective the communication will be. So let's go to the next slide here. Okay. So I think one of the key issues here to consider, and this is an outline, I'm going to go over how do we compare risks. We'll look at risk communication in what I've called the ecosystem, and that's a point that I think Sid and Supriya certainly made already. We'll look at how behavior change theories can help us evaluate the effectiveness. And I really want to say a little bit about vaccine communication. There was an excellent piece posted just a few days ago on BBC Media Action that I thought gave us some really valuable pointers in terms of vaccine communication. So, next slide, please. So, here's just a question to think about, okay? We all face people, regions, countries, all face all sorts of risks, all sorts of emergencies. And I've worked quite a bit in South Asia, most recently in Bangladesh, which gets flooded every year, gets cyclones. And, people know what to do, and governments know what to do when they get a cyclone, or when, in Assam you get flooding from the Brahmaputra. We know there's going to be people displaced. We know there are going to be waterborne diseases. People are familiar with the risks and how to approach them. We're well rehearsed, I think, at trying to deal. We don't always deal with it successfully, but we kind of know what to do when faced with other diseases, cholera and malaria, for example. So why do people take precautions about safe drinking water and mosquito control? But when it comes to the virus COVID-19, many people have not adopted the kind of behaviors we expect them to adopt. So, I think that's kind of one question for this whole webinar. Why do we view some risks differently from others? Next slide, please. Okay, now, whoops. No, I think you're backing up there. I think we're missing. We're doing this in a PDF, are we? Right. Go down to the next slide after that one. Well, it's a graphic that has not appeared there. Okay, all right, I'm going to have to describe it. This is the, just hold it somewhere there. What we should have in here is something called a social ecological model. And I think every speaker so far has sort of talked about this, but this is sometimes described as an onion, where we need to consider how communication functions at different levels. So we have individual communication, we have interpersonal communication, and then we have groups and organizations we communicate with. So we recognize that there are communication works in different ways and different levels, and that people in their responses and their behavior are open to communication at different levels, from family members, from friends and people in their community, from their religious organizations, from government health workers, from media. And so we need to recognize there are multiple communication approaches that can be taken. And this comes back really to the point that Sid was making about evidence-based research. We need to figure out, and it is contextual, it is local, which sources of communication people trust. I mean, governments like to believe that government workers are trusted. I think there was one slide in there, the research that was done in Sid's presentation, which sort of indicated that government health workers did have a reasonable amount of trust, but that's not the same everywhere. Okay, in some areas, governments are distrusted. So we need to figure out who the influencers are, who the most important sources of the communication are, which media people use, which people they don't use. Okay, we can now move from this lovely blank slide onto the next one. Okay. Right. So, there's been a lot of research on this, but it is fairly typical for governments and scientific experts, including public health experts, to, now it's gone very small here, to think that expert communication is what works, okay? You provide the scientific data and people will go, oh, that's right, I'm going to do that. Well, as I think Supriya, Mantralika and Sid have indicated, and I remember what Supriya talking about the emotional side of the head, people don't always respond in that way. Experts and the public may have different perceptions of the same risk. So somebody with a background in epidemiology is going to have a very different take on COVID-19 from somebody who does not have that scientific background. So I think we kind of agreed. I mean, it's been said we've got to listen. Listening is so important. We need participatory approaches because experts and government agencies are not always trusted. Now, and I want to kind of make the broader point there that it's not just about health. If you don't trust the government on taxes, if you do not trust the government on how it spends its money, if you don't trust the government on environmental protection, you're probably not going to trust the government on health. So, it's not as if we trust government health experts and don't trust other government experts. Somebody from the government, somebody from an official agency, they simply be distrusted because they're from the government. So that's a big challenge, I think, in public health. So we know also, as I said, that people get their information from many sources. The infodemic, as I think Supriya described it. So very difficult to keep messages consistent when there's so many conflicting messages coming through, and rumors and disinformation. Next slide, please. There's a quote, just a great quote from WHO there: trust is the currency of transaction. It's really all about trust. That's what Supriya said it all boils down to. Next slide, please. So these are just some of the goals of risk communication, which I think we've pretty much gone over, and social, religious, cultural, political, economic aspects of risk need to be considered. And this is sometimes, I think, where the public health experts get it wrong, because they're talking simply about the health part of it. And I think, we've seen in many countries, including the United States and certainly in India, that, there's an economic balance that's being drawn. That's why, people are making decisions. I do remember reading when COVID-19 started really spreading in India, day laborers were stranded in their cities. They were not able to move. And people said, I'm going to die of hunger before I die of COVID-19. And so I think that point is really important. It's not just a health issue. It has to be considered in this broader context. Next slide, please. We're talking here about the type of risk, and I think this is a fairly useful way to start thinking about it. Okay, so and I'm sure some of these questions are in some of the research that UNICEF and WHO are doing. Is the risk something new? Is it unfamiliar? Is it something that can be seen or sensed? You see the flooding happening, you see the cyclone coming in, but you don't necessarily see, you can't see the virus spreading. Are the risks from a vaccination campaign? People think about, will it affect future generations? I'm thinking back to, I forget who made the comment here, but how in the culture, people say, I want my children to be vaccinated. Well, that's a concern about a future generation, but in fact, that may be the wrong approach because it's older people who are most in danger there. Is the risk going to be catastrophic? Is there unequal harm posed by this disease or this emergency? And this comes back to, I think the Vice Chancellor was saying there, are specific groups in society affected? And I'll come later to a comment from a colleague in South Africa who, in response to an article, said, well, it's all very well to have, all of these cautions that we should be taking in terms of social distancing and hand washing and all of that. But, if you don't have water, if people are living in poverty, the kinds of behavior that are possible in a more affluent society or, certainly middle-income country are certainly not possible there. So, I guess I'd like you to think as we go through this webinar, which of these kind of factors apply to COVID-19 and, again, how we assess the risk of COVID-19 versus the other much more familiar diseases such as cholera or malaria. Next slide, please. All right, okay. Well, I'm an academic, so I'm going to have to throw in some theory here, okay? And I simply rely on this great quote from the social psychologist Kurt Lewin: there's nothing as practical as a good theory, and the best way to understand something is to try to change it. Sid was pointing out earlier, the need for evidence-based interventions. And I would say, absolutely, agreed there. And we also need to have some understanding of human behavior, individual and collective, and why people may or may not change their behaviors. And for that, we need some theory. So let's just go through very quickly 3 theories here that I think may be applicable. I mean, there are literally hundreds of health communication theories. I'm not trying to privilege any particular ones here, but I think that when we think about how we design communication interventions, we do have to have them informed by theory. Let's have the next slide, please. Okay. This is a health belief model. I think it's pretty straightforward. This is the way in which people weigh their behaviors, weigh the risks they're going to be taking. Do I believe I'm going to get COVID-19? Perceived susceptibility. And I think what we've seen with a lot of young people is, they believe they may get it, but, the severity of it, the second column here, they don't believe they're going to die from it. Well, certainly young people have died. What are the benefits of the advised action? social distancing, mask wearing, hand washing. What are the barriers? Again, coming back to the point my colleague was making in South Africa, if you don't have ample water or clean water, then hand washing is quite a challenge. Cues to action and self-efficacy, confidence in one's ability to take action. So I think the health belief model, this is kind of an interesting way to sort of think about the way people may approach the changes in behavior that we are asking them to take in response to COVID-19. Let's have the next one, please. All right, this is here. I could have a lot of fun with this one. Yeah, so where does Donald Trump appear on this one? He would certainly be in the laggard category. So, this is the Everett Rogers standard diffusion curve showing how a new practice, and in this case, we could be talking about mask wearing or social distancing or hand washing, how that diffuses through a group or a community. And so we have, the innovators, probably the health professionals who are adopting this, and then early adopters, then early majority, late majority. I would say the standard diffusion curve looks quite a bit different in some countries from others, and I'll be really interested to see as the research comes through how this is plotted. And we may also be able to look at this kind of from a socioeconomic standard in terms of education levels and things like that. But the point being here is that a new practice is adopted. Now, this is a big problem in an emergency. In an emergency, you need a lot of people, to take the new innovation or the practice, hand washing, social distancing, mask wearing, very seriously, very quickly. So you really need that curve to be really big at the beginning. Okay. That, I think, has happened in some countries, certainly not in the United States. And so, think about that. Let's do the next slide, please. And these are some of the tests that people will apply in deciding whether to adopt a new practice. Its relative advantage, its compatibility, how difficult it is to do, can we test it and experiment it, and does it produce tangible results? I think these are interesting categories, and I think, the research is still out on the degree to which this will apply to COVID-19. Let's look at the next slide, as we're kind of moving up in terms of level. And this is a gender setting theory, and this really shows how, the interplay between gatekeepers and media, public policy, and people's actions. So there's this kind of circular movement between the media agenda, the public agenda, and the policy agenda. So the notion here is that when something becomes important enough in the media, it gets a lot of media coverage, then it becomes important in the public agenda, and then eventually in the policy agenda, then eventually the policymakers start doing it. Again, this is somewhat complicated. I mean, it's not a simple equation here, because we have personal experience and other communication influences which are conditioning how we view things there. So I would say that in the case of COVID-19, agenda setting is certainly important, but it has not been even. There's been a lot of effort here to get positive media coverage, but there's also negative media coverage, and the public agenda has been somewhat confused, and certainly in some countries the policy agenda has become confused. So, those countries which have been successful, I think, have had good government policy, which is supported by the public and supported by the media, but that certainly has not happened everywhere. Let's go to the next slide, please. Right. I wanted to draw this distinction here. I mean, we talk about communication for development, but I think we need, in the case of COVID-19, and indeed in other areas, to break things down a little bit. There are different categories of behavior. There are what I would call specific or time-bound decisions and actions. things you do once, or in the case of vaccinations, twice. So, I've been tested 3 times, negative every time. I'll probably be tested again. I will get vaccinated. It'll be twice. So these are very, very specific things. Today I'm going to go and get a test, okay? Or today, whenever it happens, I'll be vaccinated. Now, but the more difficult thing are the behaviors that have to go on all the time on a consistent basis. The mask wearing, social distancing, hand washing, avoiding gatherings. Those are things that have to become part of daily life. They have to become almost social norms, things that people will do without thinking about it. Okay? And it's been, I'll just share a very interesting sort of conversation with you here. It's very interesting to visit supermarkets in the United States. If you see somebody in there who's not wearing a mask, people will start shouting at them. Okay, because this has now become unacceptable behavior. A few months ago, people went, "Oh well, it's your choice." Now I go into a supermarket and somebody's not wearing a mask. Well, firstly, they may not be let in the first place. But if they take off their mask in the supermarket, people will get quite angry with them. So I think we're perhaps moving towards mask wearing as a social norm. Rather late, with 3,000 people a day dying in the United States. Anyway, the point being here that we may need a different strategy to address vaccination or testing from one which addresses mask wearing and social distancing, because these are different types of decision or action. Next slide, please. Okay, I wanted to kind of conclude here with just some, if we'd been doing this webinar a month ago, before when vaccines were on the horizon but none had been approved, then it might be premature to talk about it. But I think we really now need to think very, very carefully about vaccine communication and how the vaccine communication programs are going to differ from those on testing and those on social distancing and mask wearing. And just a couple of points here. First, people have made the point. There's a difference between a vaccine and vaccination. The vaccine has to get into people, shots in the arm. So these are really the 3 essential elements, and I would defer to Supriya as the public health expert, because I'm certainly not, to build on this. We need to have an adequate supply of vaccine, and it has to be either free or very low cost. If you make it too expensive, then you're going to exclude a lot of people. And it has to be accessible. You don't have to travel for 2 days and lose work and money in order to be able to get that vaccine. And thirdly, and this is the communication part, we have to believe that the vaccine will work, it will be effective, will not have serious side effects. And so communication is really, really important to help build trust. But at the same time, if we even if we convince everybody that the vaccine is good and then it's not available, then, then the communication will be distrusted. So these kind of, parts of the equation, I guess we call them all parts of the supply chain, really have to come together. Adequate supply, accessibility, and trust. And then the point at the bottom, which is what I started thinking about, and I have no clue how to answer, but maybe Supriya or Sid will have some thoughts on this. If you have more than one vaccine available, do you have a choice? How do you compare one vaccine with another? You're not a scientist. So I think that's going to be a kind of interesting one in some countries where, there may be one of the, European, North American vaccines available. There may be a Chinese vaccine available, maybe a Russian one. Well, maybe the Chinese one's cheapest, Do I go for that? There's some really kind of difficult and interesting, I think, questions coming up. Next slide, please. So the other day I came across, just in my email, some comments on a new article or a blog post, and I really wanted to share this with you, and you can look it up. It's easy to find. It's by Yvonne McPherson from BBC Media Action. And the article, which was also reposted on the Communication Initiative, is called 5 Mantras for COVID-19 Vaccine Communication. Now, I've got a bit of a problem with the word mantra because I know that has a much deeper religious significance in Hinduism and Buddhism. And, in the West, the word mantra is kind of widely used for something. Maybe it should be just 5 guidelines for COVID-19 vaccine communication. Why it's a mantra with all of that added meaning, I'm not sure, but that's okay. So let's go to the next slide, and I think there is some really good common sense things there. Okay, get a hell of a challenge. We can't wait. We need to act now. So they point out, McPherson points out that some people say, oh, well, before we do vaccine communication, we just have to get the supply chain in order and make sure all of those things are working, that, we have an adequate supply and it's available, and we have staff that are, that have the, the skills and the equipment to administer the vaccine, etc. And, she argues, I think, very convincingly that, that may be the scientific approach, but the way people react, people are thinking now, am I going to get the vaccine or not? When will I get it? People are already forming their opinions. And we also know that there are groups that are likely to resist vaccine. The latest public opinion polling I've seen in the United States indicates that around 40% of people right now say they're not going to get a vaccine, which is quite scary in a way. Now, maybe that needs to change. So we can't wait for the vaccines to be there. We have to begin vaccine communication now, or should have started already. Next slide, please. The science is going to need some art and craft. Okay, we kind of made this point already. We need data, but people generally don't absorb scientific data very well. We need to look at the local, the cultural context. We need to look at people's religious beliefs, and we need to respond to people's real fears, and we need to do this with narratives, and again, I think Supriya and Sid made this point, that focus on dialogue, that are participatory, not top-down preaching narratives. Next slide, please. Global problem requires a local shot in the arm. Okay, now let's make some of the same points here. That while I think we can gather evidence and come up with some principles for communication strategy, global campaigns are probably not going to work. We need different strategies for different communities. I think this has been made very clear several times so far, so I'm not going to stay on that one. Let's go to the next one. Here we are. Okay, my little graphic did pop up again. This is the social ecological model, and we simply need to recognise here that that people do not get information on anything, certainly not on health, from a single source. They may get it from family, from community, from organizations and government workers, religious leaders, and then there's this kind of policy and media framework about it. So we need different strategies. And also, we can't have the same strategy for the same audience. I mean, health workers need to know something different and different behaviors from other groups. So the way in which we approach religious and community makers, or the way in which we approach journalists and editorial decision makers is going to be different from the way in which we approach other groups. So different communication strategies for different groups, and I say also very much need to be localized and contextualized. Next one, please. And I thought this was a really interesting point that Macpherson made. I'm just going to, I mean, we know it's going to be a long-term campaign, but the point at the end, the vaccine is going to be available to different segments of the population at different times. And so right now, the communication needs to be with, probably the two target groups, the primary groups, are going to be health workers. And, there are health workers who say they're not going to get the vaccine. Okay, that's concerning. So, there needs to be a communication intervention that's going to target health workers. And then there needs to be a communication campaign that targets people in, what shall I call it, my demographic, okay? Older people who are more at risk, who may have pre-existing conditions. So I'm not saying we leave young people out of this here, we leave social media out of it, but that will come at a certain time. Right now, because we know we expect certain segments of the population to get the vaccine at, earlier rather than later, that's really where our efforts should be focused. So the communication interventions and the strategies are going to have to change over time as the vaccine becomes available to different groups. I think that's maybe my last slide, is it? Any more slides? Let me just finish with this one. Okay, so I referred to this earlier. Sue Goldstein from Seoul City, a well-known, well-renowned communication for development organization in Johannesburg. Lovely person, by the way. So she's commenting on this post by Yvonne Macpherson on the 5 mantras. And I mean, she makes this real point, and this comes back to what Dr. Jean was saying about vulnerable communities. If people don't have running water, or they don't have money to buy masks, or even food, infection control is a lot more difficult. So we need to consider it's the equity question that Sid was talking about. We need to consider what we need to do there. So telling people what to do if they don't have the means to do it is not effective communication. And I love this quote. Sending messages to people in the scientific way or trying to scare the boots off them just doesn't work. So fear messages are likely not going to work here. And then she ends by saying, look at one of the most sophisticated countries in the world where the virus is spreading like wildfire. Throwing messages doesn't seem to have worked. Last slide, please. I wonder which country she's talking about. Okay, let me thank you all very much, and I'll be really happy to take some questions, as I'm sure Sid and Supriya and Matulika would be too. Thank you so much.
Thank you, David. I think we can have questions. People who have questions can post their questions in the chat box.
Let's see.
As we have the questions coming in, I don't see any questions right now. Till that time, David, one point you have been talking about localization of communication messages as well as strategies. This local has to be really, really local. When I'm thinking from a context like India and the multiple cultures that we have, realities, the extent of localization of message delivery and strategies will have to be really very significant in a country like India. So something really food for thought.
Oh yeah, I would, I absolutely agree. I mean, India. I mean, I don't want to say anything wrong here, but India's many countries, isn't it? Really, many countries, many cultures, many languages, and so it has to be really. Now, I mean, there's a challenge here. Well, one of the terms that development agencies like to use is to have an intervention that is scalable, something that you can do, that you can start somewhere and do a lot of other places. So so obviously the costs of extreme localization of strategies are relatively high. So, I mean, we may need to find some middle ground here in which, strategies are developed, but then, we make sure that they are language and culture sensitive, adapted there. I mean, Sid would go crazy if he wanted him to develop a communication strategy for every district,
Yeah, great. I have this one question coming up from Aisha Tahera. In a developing country like India, isn't there an overemphasis on health communication when the focus should instead be on health literacy? So should we not focus more on health literacy than on health communication?
I would like to kick that question to a public health expert. I would maybe like to hear what Supriya has to say on that. I have some opinions, but I would prefer somebody else to respond on this one.
Supriya, would you want to take that question? I think either she might have left the meeting. Madhulika, would you want to answer?
Could I just get the question again, since it was...
Yes.
Yeah.
Aisha Tahira was asking that in a country like India, should we rather emphasize on health literacy rather than on health communication?
I think you can't do one without the other. And then I have my communication colleagues to say that. I have David and Sid there. And as public health person, I think definitely health literacy is important, to know why we do what we do, because it really substantiates the whole piece on behaviors. Because communication is largely to change behaviors. So I don't think that we can successfully get results only doing health literacy or only doing health behaviors. I think knowing both, especially in a pandemic situation where there's a lot of misinformation and other things, I think both would be equally important. Unless, David, do you have some evidence? Right now, I am not speaking from a position of evidence, but speaking more from a position of things and the way they have panned out for us in the South.
Thank you.
I'd agree with your assessment there, really. Yeah,
David, I think this question is for you, where someone is asking, do you agree that diffusion of innovation works in context of behavior change? So we hear a lot of criticism of diffusion of innovation. So in terms of behavior change, you have also referred to diffusion of innovation. So does it work in terms of behavior change?
Oh, well, it's one of those answers. I have to say, it depends. Okay, so I mean, there've been quite a few studies that have shown, for example, in water and sanitation, and should we say, people taking precautions about to prevent malaria and things like that. I mean, there's quite a bit of evidence that's shown that it can work. The problem, I think, here is that it doesn't work terribly well in an emergency situation. So, if or we'll take a completely different thing, early marriage. Okay, right? There've been studies that have shown that over time, maybe over generations, people will abandon child marriage, early marriage, with lots of communication inputs. Now, but when we get to COVID-19, we need a whole lot of people early on to do the right thing. And that's been the problem. At least that's been a problem in the United States. That people have not done the right thing. They've resisted it. They have not taken the advice of medical experts. And so, with something like the virus, you need a diffusion curve that looks a lot different from the kind of the standard one of the early adopters, the innovators, the early adopters, the majority, and so on there. So I think it's less applicable to emergency situations. I mean, I used it there partly because it indicates, again, why people will take decisions, is something they can observe, it's something they can try out, can they see the results, how complex is it? So, I think it provides some clues as to why people and in communities will adopt certain behaviors. And again, if you look at mask wearing, I think I think we've kind of moved from a situation where very few people were wearing masks, even though they were told to do so, to, in some countries, places where it has now become the social norm. So we're now kind of at the, at a point on that diffusion curve, where maybe the majority, at least in my community, are wearing masks. But it's taken a long time to get there. And the timeline is a it's a really difficult point. I mean, if people had been wearing masks in April and May of this year, we would not be in the situation we are in today in terms of deaths and hospitalizations in the United States. So maybe the diffusion curve applies, but for COVID-19, for any emergency, that timeline really needs to be compressed.
I think there is another question for Supriya. Is Sid around, and I can ask him that question? Or otherwise, probably Madhurika can take it, that the plethora of infodemic on social platforms has become the high prevalence of mental health problems during the COVID outbreak. Are different ministries and organizations like WHO working on different strategies or collaborating to combat it and monitor the false information? So basically, Sonal Mishra, she's trying to ask that we see a lot of infodemic and misinformation, and whether there is a collaboration between the different international organizations like WHO, UNICEF, and the different ministries in order to combat this misinformation which is leading to mental health issues during the pandemic?
No, thank you. I think this is a very interesting question because it has both the issue of working together. Definitely UNICEF and WHO, and I would even say UNDP, we have worked together and brought on the academia. I know that we have worked very closely with NIMHANS, which is based out of Bangalore, which is a very national mental health institute. And then locally also worked with various mental health professionals to provide mental health, I would say, psychosocial support both to young people as to others, because I know that we work very closely with adolescent groups to provide this mental psychosocial support. And so definitely the teams are together. They are also looking at various platforms where this mental health psychosocial support can be offered to different strata of, either adolescents or young people. And ministry has taken it up very seriously. The other piece that I just quickly share, it's quite late, here is the point of stigma and discrimination, and where a very important campaign, because it did become very, very stressful for people, a very strong campaign from Government of India supported by UNICEF and WHO was, taken up to reduce stigma and to create more kindness in the time of the pandemic.
There was also this phenomena when we saw that the factor of lockdown and people staying at home was also leading to a lot of mental health issues. So that also gave rise to a heightened problems of mental health issues, especially among the young people.
We also, sorry to interrupt you, Dr. But we also had a lot of new cases of, abuse, child abuse, gender violence, in the same thing. So it was a lot of stress and mental health issues, largely also driven by violence within families, largely within families, among children, women, where they were, stuck together because of the lockdown.
Okay, but we have another question from Kathakali that vaccinating the entire population is a daunting task, both in terms of economy and communication. Is it practically possible to vaccinate the entire population? Does the entire population need to be vaccinated in the first place? So I think Madhulika, you will have to take that question.
The way the Government of India is looking at it, because they have only started the master trainers for the rollout of the COVID vaccine, and the way they are looking at it, and different states are also prioritizing. So definitely first responders, frontline workers, the health professional, I think those are the first in every country. And then looking at the ones, at the older people, so in some places it's above 60, in some places it's above 50, and even for those adults who are below 50, if they have very serious comorbidities, then they are looking at vaccinating them. So I think the whole approach of the government, and I would really want WHO teams to comment on this, but what I have understood and what the government has been sharing, and what WHO has been sharing, is that largely the whole point is to reduce the most susceptible group. To vaccinate the most susceptible group, so who are more at risk of morbidity or dying. Morbidity is getting the infection or dying of the infection. So I think that is the premise. So the whole point, as the person who has asked this question, that will everyone be vaccinated? I think that is the hope, but that is not the logical. It will be phased. It will be by phases, because there is not that much vaccine and we need that many vaccinators, that many syringes, that many cold boxes. So there's a lot of logistics behind it. So I think the way the government is looking at it is to first reach out to those who are most susceptible and to those who are first responders and healthcare workers.
David, I'm not sure, maybe on a lighter note or a serious note, there is a question from Yagna Mishra of Amit University, and how much is Trump responsible for COVID-19 spread in the US?
Yeah, I saw that question in the chat box as well. I wondered if you were going to skip over it.
I think that is more on a lighter note.
let me just make the point here that any political leader in any country is, it becomes a role model. Okay, and we talk about influencers, and we talk about people, taking cues from the behavior of their leaders. And and these can be political leaders, these can be cultural leaders, these can be people who are respected. Now, I need to be a little bit careful about this. Trump did not create the pandemic at all. However, early on, he disagreed with his scientific experts, downplayed the seriousness or the potential seriousness of the pandemic, and then I think most seriously failed to adopt a national strategy. So I made the comment before that in the United States, the response, both the medical response and the communication response, has been decentralized but not contextualized. So here I live in the state of West Virginia, and the communication response is completely different from the neighboring state of Ohio or Kentucky or Pennsylvania. Every state's being left to handle it on its own, which means that people are getting conflicting messages. So, the Trump administration, I think, does have to bear responsibility for a late response, a tendency to minimize the seriousness of the pandemic and how it might spread, and also in terms of simply modeling behavior. Trump is frequently seen without a mask. Okay? And not social distancing. They're still holding parties at the White House, this month, where people are gathering together without masks. And so if your leaders do that, and let's remember more than 70 million people voted for Trump in the election, then many people are unlikely to adopt the same behavior. So he's not wholly responsible, but he has certainly, I think, his actions have certainly contributed to the effects of the pandemic being worse in the United States than they could have been. It would still have been really bad, but we might not be getting 3,000 people a day dying, and hospitals absolutely overflowing with serious patients. So I guess that's all I will have to say without getting too political.
David, there are two questions which are connected, I would believe, and let me read those together. One question from Shubhendu Bhattacharya, and he is asking that this pandemic has shown us the myth of development. It has shown digital divide. It has shown unbalanced growth and development. So do you feel that centralized health communication, ignoring political economy of the country, will work? So this question is in terms of centralized health communication, talking about the disparity in development which is there in a country like India. And there is also another question which talks about the digital divide which is there in India. And also another question where we see that there are lots of disparities between in the rural sector. So what sort of an emphasis in health communication can we have in terms of this sort of a context that we see in India? Like Riddhi Bhargava is asking, when we talk about India, a developing country, risks are too many, but when we evaluate in comparison to various other needs, the situation for rural India becomes more difficult. So what could be the strategy to surpass it? David, if you want to take that question. David, you have to unmute yourself.
Can I defer to Madhulika to begin with, and then maybe build on what she's going to say? That I think would be the best thing, because I know something about India, but I would prefer to hear her perspective first.
Yeah. The first question is, this pandemic has shown us the myth of development. It has shown digital divide. It has shown unbalanced growth and development. Sir, do you feel that centralized health communication, ignoring political economy of the country, will work?
Do you want me to go first, David? Yes? Okay.
Yes, please go first. I just had my screen drop out a couple of times. I've just had to rejoin the meeting, so I didn't hear the whole question there. So why don't you start, and I'll if I've got anything useful to add, I will do.
I think this is a very interesting question, actually thought-provoking question, Mr. Bhattacharya. And the fact that he's talking about a centralized health communication, because definitely as a country, I'm speaking for India now, the communication has been very, because the communication strategy, the communication messages are engendered together with technical bodies like UNICEF, WHO, and then sent out. And then we are looking at, again, you're talking about the political economy, and then, as David said, giving messages which cannot be followed. So giving simple examples of, physical distancing for migrant workers who were put up in probably small shelters. And so there is no scope for physical distancing, because it's a small place, and then when they live there, there's really no place to this thing. So a large part of the messages can be, the health communication is reaches out to the people who are able to practice maybe 60, 70, 80% of that. But then there is always that part of the communication which is, I would say, easier to follow. The wearing of masks, the washing of hands. And there was also a discussion at some point that, we are talking about sanitizers, which is like, something that is expensive, but then what about the places which really don't have much water? And so we are talking about a communication message that is difficult to follow in these situations. When we talk about the political economy, I would want to understand, because what exactly you, Mr. Shivendu, wanted to ask, but also looking at the livelihoods lost, and that is what you were indicating, the livelihoods that were lost, and we understood that because livelihoods were lost, children, because we are working closely with children, a lot of malnutrition. And we are looking at a lot of our data coming into us, a lot of essential services of take-home ration from the Anganwadi centers, immunization. During the months of April, May, June, it was a big slump. But what happened is later they have picked up on those services, and so many things have restarted. So agreed on the point of, and I'll look to David for his comments, but agreed definitely on the point that for the most vulnerable and for the children living on the peripheries, I think this point is definitely something we want to look at, and so we look at the most non-negotiable behaviors which will, I would say, save lives in that sense, and then look at the other points that were spoken about on lost livelihoods and people who were on the move, and people were displaced and hence were not able to access many of the regular essential services of the government. I don't know if that answers the question Mr. Bhattacharya has raised.
I thought that was an excellent answer to the question. I think you really addressed the point very, very well there. And again, it comes down to context, and we have to encourage or the behaviors that are reasonable and practical in the context, bearing in mind people's living conditions and their economic conditions. And I mean, and this is a kind of a broader question about development anyway on this. Health issues are not just health issues, they're economic issues, they're education issues. I mean, we know that, people that, health literacy and health awareness and people's health behaviors, have a relationship to their education levels. So if we improve education, if we improve economic conditions, health will, health will follow to some degree. These are all interlinked. And I think the problem we're getting a little outside communication here, but I think the problem here in some countries, in many countries, is that government ministries are divided. And so the Ministry of Health is fighting for budget funds against other ministries. And, we need kind of integration there for, the Ministry of Finance or the other ministries to recognize that what they contribute to people's livelihoods, may result in better health outcomes. And, otherwise we have this kind of silo approach to development where people are fighting for funds, and we need to sort of think about how health, education, economic well-being are all, and other areas, are all related to each other. But that's a big jump for governments in particular, which have traditionally been divided amongst ministries and fighting over budgets. Okay. Madhulika, that was an excellent point.
He also adds a few questions to it where he is asking that the incidence of child labor, school dropout, child marriage, missing and trafficking of women and children, malnutrition are increasing. So what sort of C4D approach do we need under such a situation? And there is another question from him where he asks that this pandemic has shown the bankruptcy of the public healthcare system both in the US and in South Asia. In such situation, how can we expect that the vaccines will be distributed equitably? What should be our communication strategy to reach to the most marginalized? So I think in terms of vaccination, Madhulika can answer that, how we are going to reach to the most marginalized, and probably David can talk about a communication strategy which will be holistic to look into the other issues of child labor and school dropouts and child marriage under the current situation, and how we can probably have a communication strategy to help overcome the shortcomings of the public healthcare system.
The vaccine question is really a very WHO question. And, when you're talking about vaccine safety, it's really WHO who comes in to, speak about that. And I think what will happen is that while we are waiting for the, while we are waiting for the actual vaccine, because Pfizer vaccine has been shortlisted as a vaccine that will go out, but still there are pieces that are not that have to be shared officially, and I think that's where Mr. Bhattacharya is coming from. So I will really not comment on that and leave that for WHO, and probably can reach out to WHO, and I can facilitate that and come back to them. I think before David goes into the point on this thing, because that is something we have been following, increase in the instance of child labor and school dropouts. What we have seen is that especially where children are marginalized, wherever the whole issue was not going back to school. So wherever children were not able to connect with education, where parents lost livelihoods, and where children did not connect with the classroom, there was a school dropout. That child dropped out, and because there was also a need for I would say finances within the family, many children who were a little bit older, towards the 14 and a half, 15, 16, they were pushed into child labor to support families. And also talking about child marriage trafficking, our experience also shows that wherever, and also we know that there have been instances reported by media on, especially in the state crime records bureau, of instances of trafficking and also instances of child marriage. So those instances definitely have increased. And before, not to take away from the communication part of it, I really feel that there are also technical solutions beyond the communication solution, which must not be forgotten. So going back to school is firstly the most important solution. The digital divide, making classes available to children, connecting them either with home-based worksheets or with teaching learning material that is shared with them, or a teacher who is willing to take a classroom in the open air. I mean, many teachers and many volunteers came forward in different states, very excellent examples of champions who actually came forward to teach children, keep them connected, and not allow them to fall off the bandwagon. So when we talk about child marriage, I think it's so much more, especially for girls within Assam, that wherever a girl was not going to school and sitting around, and where there was no livelihood, and she was considered a burden and an extra mouth to feed, they married her off. So I think these points are interlinked. And we need also the technical solutions, the social protection schemes that would come into actually, provide either the additional grain or the additional finances to continue to uphold families, so that they are not pushed into, marrying off their girls or trafficking the children, sending them off to work. I think that technical solution would also be very, very important. David, over to you.
I thought that was very well laid out, and I really have nothing to add to that. Simply to sort of go back to the issue of, communicate. Communication is part of many interventions, many development interventions, but by itself it's not enough. So just as in vaccine communication, you need communication, you also need the vaccine. In terms of school dropouts, you need the schools to be open, or as you say, the teachers to be prepared to teach in the open air, or you need to provide tablets to the children so that they can connect. So telling people go back to school, it's a good idea, in whatever communication way, is not sufficient by itself if they do not have the means and the facilities to achieve that. So, we really need to think about supply and access and communication as part of the whole solution here. So I've really got nothing more to add to that. Matulika, very well said. I thought that was nicely summarized. Thank you.
Joya, just to comment, we also have Suresh, who is our specialist. So Suresh, if you have anything to add, maybe even you can come in with your experience in Assam.
Let me just say here, I'm going to have to leave in about 5 minutes to go to the doctor. Okay, actually, the person who should probably go have the medical appointment is probably Dr. Chakraborty, who's done a wonderful job here under great stress of managing this webinar so far. So, okay. Anyway, but so.
We will. I'll take the last question then, and maybe the other questions I can forward to you over mail, and then we can respond and send it back to the participants.
Certainly, happy to do that.
Yeah. Yes. So I'll do that. Maybe I'll just end with the last question, which is a little different from the others, where we have a question where Rajdeep Chatterjee is asking how to counter fake news. We have seen this in the case of migrant labor problems. They got a WhatsApp forward and came to the bus stand. I think that's an obstacle. How will we be able to deal with that through some strategy? So in terms of misinformation and the social media, how would we be able to deal with that?
I don't have a solution to to this. This is a very, very difficult question here because it's, you know, it's easy to label something as misinformation, but as we know, if somebody believes something, you know, strongly, then it becomes very, very real for them, and it may not be misinformation. So, there's a big move in certain countries now to clamp down on Facebook and Twitter and stop misleading messages going out, and I understand that. But there's also, I think, on the other side, there's some principles here of freedom of information. In the United States, we have the First Amendment, and so I worry about, appointing any government officials to police this. Right now, there seems to be some self-regulation in Facebook and Instagram and WhatsApp on some of these issues there. I mean, it's a huge issue. I don't have any answer to it. I mean, it's the infodemic, as I think Supriya said, where we're getting so much thrown at us. And I'm not sure that simply removing misleading messages from social media is the answer to the issue there. I think basically our communication has to be better. We've got to do a better job here of making more convincing, fact-based communication to counter all the other stuff. Because I don't know there's any way to stop it. I think that working with influencers, and I'm not just talking about social media influencers, I'm talking about community leaders, religious leaders, and people in politics and people in the entertainment industries who people respect is very, very important. I think they do have some clout there, but no. I mean, this is a huge issue. I mean, there will be a lot of misinformation out there, and it's almost impossible to police it. Even if it's taken down too late and has already been shared. So I think we've just got to do a better job as communicators than those who are putting out the misinformation, which is a kind of a trite thing to say here, I know, but in this really crazy free market of information, we've got to cut through the clutter and come out with the messages that convince. And again, I think coming back to this issue of dialogue and participation, it's not a slick TV ad campaign. It's working at these different levels in the social ecological model to provide a consistent message. So if we're hearing the same thing from community members, and religious leaders and health workers and the media as well, then I think people will form attitudes and form behaviours. So, but it needs to ensuring that consistency means a number of different communication strategies at different levels. That's really all I can say. It's a huge challenge, and there's no magic bullet. There's no simple way to solve it.
True, David. There is no magic bullet. I think the magic of the vaccine works now. That's what we have to look up to. Thank you, David. Thank you for the excellent deliberations. And I'm sorry that we are really hard pressed for time out here. I'm also let me assure the people who have asked questions that we will try and compile all the questions and get answers from the panelists if we are not able to accommodate it during the session. But I would want to conclude here by thanks, Madhulika, for being there and for answering the questions, I'd say, on behalf of Supriya as well on certain occasions, even on behalf of WHO. Thank you. Our Vice Chancellor, Professor Jain, is still here with us, and he has been attending to the entire discussions till now. Thank you, sir, for being here. This is an encouragement, and thank you, Madhulika, for all the support in helping us organize this webinar. I'm sure that we will be able to engage in some very meaningful dialogue during this entire process of 4 days that we have planned. Keeping our fingers crossed for not having any technical issues again in the next days to come. And David, thanks a lot for the way you have highlighted the theories. Those were so academic, and the way that you have connected it to the practical problems on field, that was really fantastic. I believe we can see the connection between theory and practice in the context of C4D and in the COVID-19 situation so very clearly through your deliberations. The connection between theory and practice became so clear. So thank you, David, for being here with us. Thank you to all the participants who have participated actively in this discussion. With greetings to everybody, and good morning to people in USA, and good night to people here in India. Thank you everyone for being here with us. Thank you. Have a good